Welcome to another episode of Roll Call, TTSH Nursing's very own podcast, brought to you by TTSH Nursing Organisation Development. I'm Kim.
And I'm Becky. And we're your hosts for this episode.
So it's Becky's first time on the podcast today. Welcome.
Thank you.
Can you just introduce yourself to our guests? Our viewers.
Hi, so my name is Becky. I'm actually from Tan Tock Seng Neuro ICU Ward, and I've been working here for about 2.5 years already. Yeah, I'm so happy to be here.
Okay, so we asked you guys to share with us some common medical abbreviations you've seen or heard around in the wards, and we wanted to share and discuss them with all of you today.
Okay, so let's dive right in.
So the first medical abbreviation is DM. So DM stands for diabetes mellitus, or more commonly known as just diabetes. So one funny memory that I have with the abbreviation DM, right, was, okay, so when I was a nursing student, this was like I was a fresh grad out of poly, a media student. I didn't have any medical knowledge whatsoever, and I was like this blonde girl like from MESCOM. So I was at our school's FOC. And then I remember one of my seniors, like we were playing like station games or something, and then she was just like, it was like quick fire round. So she was like, what does DM mean? What does DM stand for? And then I so confidently shouted, direct message. And she judged me so hard because she was just like, what's this stupid girl? Like, what's this stupid girl saying? Then she was like, no, wrong. Then I was like, how does it mean? She was like, diabetes mellitus. Then I was like, what is that? Now I know. Diabetes.
We learn new things every day.
Yes. So that is DM.
Okay, then next off we have DVT, which is deep vein thrombosis. So thrombosis basically is a blood clot, and it usually forms in your leg veins. So it sounds very inconspicuous, but usually what happens is that once the patient starts moving and this thrombosis dislodge, it can go to your heart or it can go to your brain, causing like a stroke or cardiac arrest. So it doesn't sound like it's much a thing, but it's quite serious. So usually how we advise patient, or even if you're not a patient, you're just a regular person on the street, you can prevent this by making sure you move, especially in a plane. And actually even at home, if you're using computer at a long period of time, you can just make sure that you get up often enough to go toilet, get a cup of water, just keep that blood flowing, keep it moving, and you can prevent DVT.
Yeah, because I think a lot of my patients that come in for DVT, usually the doctors, one of the first few questions that the doctors will ask them is, have you been on any long haul flights recently? So if you're taking a long flight, now after COVID, everyone's traveling around and all that, right? Especially if it's on a very long flight. Now, I mean, even if I take like a 4-5 hour flight nowadays, right, I'll make sure I'll stand up, I'll go to the toilet, do some stretches, just make sure your body moves around a bit and you're not like just like sitting down there so stationary for so long. The more you know. Yes. The next abbreviation is SOB, which I think is quite a straightforward one. SOB basically just means shortness of breath. So our doctors will usually document it as like, patient came in for SOB for like 3 days or whatever period of time. Yeah, quite straightforward lah, this abbreviation.
Next is NBM, which is nail by mouth, which means you cannot take anything orally, including no food, no drinks. However, sometimes medication can be an exception. For example, like you really need to take your regular dose of like antihypertension or like your diabetes medication, then you can take it with a small sip of water. Usually the doctor order nail by mouth is before procedure, or maybe if you come with like nausea, vomiting, you got like gastrointestinal issue, they will really want to prevent you from eating and causing more discomfort and distress to you already. So only then we usually use it.
Yeah. So if you're in the wards, if you're a patient, or more so like if you're visiting a friend or family member who's in the hospital, if you see this big red sign that says MBM, that means no eating. So always check with the nurses or any healthcare professionals that are around. I think, but more so your nurses lah. Just make sure that double check with them, especially if you bought them food, whether they can eat the food or not. If not, we can keep in the fridge for you.
Definitely.
Yeah. Okay. So the next one is PRN, I don't think that this is just used in a medical setting, but okay, I actually learned about what PRN stands for, like as we were researching about for this particular episode. So PRN actually is an abbreviation for the Latin term pro re nata. I'm so sorry if I pronounced it wrongly, which means as the thing is needed. So like when necessary or when needed. So usually, I think the most common place that we see this in the hospital is in our medication system, our medication app, where the doctors will order like Panadol PRN, or like maybe like some symptomatic medications like for giddiness or nausea, vomiting. So only when necessary do we give them to our patients.
Now we have stepped into the realm of Latin, because what I will be talking about next is also derived from Latin roots. So we're talking about BD, TDS, and QDS. So you probably hear this before when your doctor's prescribing you medicine. So BD actually stands for bis in diet. So that means twice a day. So morning and evening. And then TDS stands for third diet sumidem. Sumidem. Yes, and that means to be taken 3 times a day. So morning, afternoon, and night. Last one, we have a quarter di subidum, which means 4 times a day. So usually, if that sounds like, oh, how do you have 4 times a day? It's only morning, afternoon, and night. So just think of it every 6 hourly. So unfortunately, that would mean you have to wake up in the middle of the night, or you sleep late. You wake up early. Yeah.
In the wards, right? Especially when I'm night shift, and then I see the doctors, like maybe example Panadol QDS. So I will see 2 a.m. Panadol, and I always feel so bad because I have to wake up my patients like, hello, like you know they're like completely conked out, right? Then I'll be like, hi, do you want something Panadol? And I'll feel so bad. But sometimes, you know, if like let's say they're having like very frequent fevers or like pain in their legs and all that, usually we have to wake them up to give them. I'm so sorry. The next one is another pretty straightforward one. Is CM. So usually you'll be like, patient plan for discharge, CM, which not centimeters, but basically it's coming morning. Quite straightforward as well, CM.
Then we have AMA, which is against medical advice, or AOR, at your own risk. So usually these are for our naughty patients who decide to discharge against doctor's advice. But of course there are exceptions. For example, like if patient want to transfer their care to another hospital, then in our discharge we will write as AOR, patient AOR, so at your own risk. But sometimes it's just because they discharge to go to another hospital for their care instead. So it's not because patient is naughty. Okay.
The next one also starts with an ARU, which stands for acute retention of urine. So this just basically means that your urine is just stuck in your bladder and doesn't want to come out. It's just over there in your bladder. Which leads to our next one, which Becky will explain further.
Yes, which is IDC and IMC, which is your cure for your ARU. So IDC means indwelling catheter, which is, as it sounds, the catheter that's inside you in your bladder to drain out your urine, which will keep there until we feel that we can try to remove that catheter and let you pass urine on your own. Or if you have a chronic illness where you are not able to relieve yourself, or your bladder is not able to pass out urine as per usual, then we will put in an IMC, which is intermittent catheterization. Sometimes patients can do this on their own with education as well. So what they do is they just put in urine catheter in. Once they pass out the urine, and then they will remove it. So they will do this depending on their preference. So maybe like
BD.
Yeah, Q6. Yes,
correct. So usually the tubes, the urinary catheters that we usually use for IMC are usually a bit smaller than the IDC, because it's just like a in and out procedure. Very, very quick, very fast. And I know patients who have done it that like they do it for themselves as well, compared to a IDC where, you know, like the material is different. It has to last, because we usually change it like every 2 weeks. Some of them can last even up to like a month max. Yeah.
Yes.
Yep. So that's the difference between IDC and IMC. Okay, the next one is also a bunch of them that will be kind of like mushed together because they're all kind of related to one another. So the first one is LOC, which means loss of consciousness. So basically you pass out. So this is very commonly written, I think, like in emergency department notes when patients come in, they're like unconscious. So usually, you know, like maybe we gather the details from their family or like any passers-by who were around. So they'll say like, oh, LOC for 10 minutes, or the patient LOC for even like 5 seconds. Then Related to this, there's also AMS, which stands for altered mental status. So maybe patients are confused or they are a bit delirious. It's just basically not at their baseline mental state, like oriented and alert. So this is AMS. So usually for patients who come in with LOC or AMS, very commonly the doctors will assess the patients, and the nurses as well. We will assess them based on the Glasgow Coma Scale. So or we call it GCS. So GCS monitoring, or CLC as well, like consciousness level charting. Comment down below which one is correct, or if I say anything wrong, please correct us. But CLC, or basically like GCS monitoring, right, is when we there's basically like this like, would you call it like a scale or like a checklist kind of like criteria kind of thing?
Actually, now that you question me like that, I'm sorry, question myself.
We do it so often, right? We do it so often, but like I think to really break it down and describe it is it is a bit.
Oh, okay. So I think Glasgow Coma Scale. Okay, in a way, Glasgow Coma Scale is the final score that you have. CLC is that assessment to do it.
Yes.
That would be an easy way to like. So the doctor will order as
CLC monitoring.
Yes, correct. But your score is known as GCS.
Correct.
Yes.
So CLC monitoring, conscious level charting, is basically like okay, so we assess things like your eye, you know, how your pupils react to light.
Correct.
And then we assess things like your verbal response, your motor response, whether you're able to follow instructions, etc. So so based on that, the highest score that you can get is GCS 15, which is basically like us now,
very
I
alert,
guess. Very alert, very
interactive,
oriented, you know what's going
live.
on, you can follow instructions. But as you know, as your conscious level, like if you're more like, oh, like what's going on, and confused and all that kind of stuff, the score goes down. So the lower the score, the more not
good you are.
Not here you are, you know? Yeah. So that is GCS and CLC.
Then next off, we have ECG, where very commonly used, and you'll probably hear in TV, maybe in the US context, EKG, but here we follow American, so it's ECG, which is electrocardiogram. So basically, it's the most simplest form of like test to check your heart rate, your heart rhythm, any abnormalities. Usually, if you come to have chest pain, that's the first thing we'll do for you. SOB, sorry.
Yeah, SOB.
Shortness of breath. Yes, we will use it as well just to check if there's any abnormalities.
Yep. Usually that's the first line in the wards, I feel like. If recently we had a patient that complained of chest pain. So the moment we did the ECG, we found out that she was having a heart attack. Her heart rate was really high. So usually this is one of the first line basic assessments that the nurses will do for you.
So you hear very often, oh, he needs like a bolus dose of IV adrenaline. So IV basically stands for intravenous, which is directly into your veins, which is the most common form of giving medicine if you cannot take orally. Then we have IM, which is intramuscular, which is through your muscle. So usually we will give vaccination or sometimes even painkillers through in IM for patient who can't tolerate like IV injection. Then we also have sub-Q, which is through your fats. Yeah. So the most common form would be your insulin as well, or the DM patient. We just learned DM. Yes, our DM patient would be using a lot of them would know what is sub-Q insulin.
Yep. So usually in the wards, what you will hear the nurses say, right, is like, has the patient BO'd or has the patient PU'd? So what that means, BO basically means bowels open. So basically you pooped. BNO means bowels not open, so you did not poop. And PU means passed urine. So usually the nurses will document this in your intake-output chart so that the doctors can see, you know, how many times did this patient pass urine. You know, I had a patient who passed urine like 10 times one night, and 1 liter of urine came out. Or you have certain patients I've seen, I think the longest time that a patient has not pooped was like up to a week.
Oh,
you know, one of those. And then you just know you're going to have to give lots of medicine and prepare for that massive one.
Whatever comes out, it's not going to be good.
Yeah.
So whatever goes out must come in first, right? So next we'll talk about NGT, which is nasogastric tube. So basically it's a tube that goes through your nasal airway into your gastric. And this will provide you, usually we give milk feeds, no solid feeds. I have seen a video where uncle actually gave himself beer through that. Yeah. Not advisable. Not advisable. Yes, but we usually give milk feeds, we'll give water, and we'll give medicine through that tube, especially when patients are not able to swallow or they're swallowing difficulties or they're just the conscious level is not there, really drowsy. Yeah, so usually we will do that.
It'll be safer because
Yes.
there's a very high risk that this thing called aspiration happens, where if patients are not, or maybe their muscles here are not really strong, or they're not able to really like, no, I wouldn't say control it, but like there are certain conditions where it might accidentally go into your lungs instead. Yeah, so that's when we have to insert an NGT for your safety. And I think some people might wonder, like how do you make sure it goes into their stomach from the nose? Why can't you put it in the mouth straight? So how we do that is that when we are inserting the tube through the nose, we'll ask the patients to swallow. Like if they can follow instructions, we'll be like, can you swallow? Like just pretend they are swallowing something. This helps to increase the chances that it will go into your stomach. Yeah, so there was actually this one time when I was a nursing student here at TTSH, one of my core memories, like when I was younger at TTSH, where the group of us, I think we were having like a debrief with our instructor, and then I can't remember, one of us or she asked like, has anyone felt what it's like to insert a tube? Since you guys always do it for your patients, right? Do any one of you want to feel what it's like to get that tube inserted? So one of my friends volunteered and we inserted the tube into his stomach. And a way for us to check whether it's really in your stomach is to check the acidity. So we check the pH level. So your stomach is acidic, right? To digest your food and everything. So if the pH level indicates that it's on the more acidic side, there's a higher chance that it's guaranteed that it's in your stomach. So we aspirated, like we took a syringe and we tried to pull out some of his stomach fluid so that we could test it, and it was brown. And then we were like, why is it brown? And he was like, I just ate a chocolate waffle.
For info, when it's brown, it means that you have potential bleed in your stomach. It's quite alarming actually.
Yeah, so we were all like, oh my gosh, dude. He was like, no, it's okay guys, I just ate a chocolate waffle. Then we were like, okay, it's chill then.
So usually, we also have what we call OGT, which is via your oral into your stomach. But usually we don't have that for patient
I've never seen that before.
Very uncomfortable. Can you imagine you constantly have a tube there and there'll be a risk of your patient biting the tube and it breaking. So we use that, but for patient with skull fracture. So if you go through the nose, you might accidentally go into your skull because there's a fracture there. So it's always it will be safer for OGT, which is oral gastric tube.
Oh my gosh.
Yeah.
Thanks for sharing. I've never seen that before. I think it's really not common in my kind of areas, but I think in your area.
Yeah. Usually with patients in ICU, especially if they have they're quite traumatic brain injury, they have a car accident. If patient might have a skull fracture, usually that will be the route to go safer.
Interesting. Okay, the next one is DNR, which I think a lot of people probably know from all those medical dramas and all that, right? So DNR basically means do not resuscitate. So that means that a person has decided not to have CPR attempted on them if their heart or their breathing stops. A lot of patients, especially I think those that maybe frequent the hospital often or they're much older, usually, the doctors will ask them or ask their family members, if something happens, how do you want us to support the patient? So for some of them, they make it very clear that they do not want CPR. So what we do is we usually support them through either IV fluids, antibiotics, but that is the maximum. We will not do CPR on them. And just now, actually, we were discussing about this, and Becky was saying that someone asked, what if you tattoo DNR on your body?
It's
if
still
I collapse
valid.
outside, if someone sees it, does that mean I shouldn't resuscitate? I shouldn't CPR you?
Yeah, if there's no legal documentation, that would be a no. So we will still have to resuscitate you and bring you back alive.
Okay, the second last one is, I think more, you really commonly see it when patients are discharging. So maybe when you're about to go home and your nurses are explaining your appointments, your follow-ups and all that with you, you will hear these two terms pretty often. So the first one is TCU, which we found out means to check up. We also heard people say that it means to see you, but I don't think that's the correct one. So it means to check up. So that basically means example, when our patients discharge, I'll be like, okay, your next TCU will be with our general medicine clinic in a month's time, so that's how we usually use it. And another one will be OPS, which stands for outpatient services. So this usually refers to your polyclinics, your GPs, who you will see outpatient, not in the hospital setting.
So for the last one, we have cow, which is computer on wheels. And I feel that is the best invention that has been created because that brought so much convenience, especially when we're nursing our patients. Not just for us, honestly, for any medical staff who needs to assess patient but actually do documentation at the same time. So sometimes you might be talking to a patient and they are telling you a lot of information, and so you need to bring your cow along. They can document at the same time while talking to them. Yeah, so it allows for timely documentation as well.
Yeah. I think the most common sentence that I use the word cow in is, who took my cow? Because who takes the cow? My phone,
I did.
girl, my phone has a K-pop, like a K-pop man a photo card at the back. So sometimes, like, that's my phone, everyone knows that that's my phone. So sometimes I'll put my clipboard or I'll put my phone on top of the cow to like chop it, okay, maybe I'm documenting stuff and then someone presses the call bell. So I'll go into the room for a while. Then when I come out, my cow is not there. Who took it? I will find you and I will find my cow.
In a hospital, your electronic devices are not valuable. The cow is more valuable. It's very important because we need to do documentation.
But okay lah, everyone is very busy, there might be a doctor suddenly who needs to come in and faster do their rounds, with their big bosses and all that. So I understand. But usually when I go back there, I'll be like, do you take my cow? Or I'll go there and I'll be like, I'll take my phone. But it's okay. I forgive you. It's fine. My name is not on the cow, so it's fine. And that's actually our last abbreviation for this episode. Thank you guys so much for watching. Remember, you can also check out our podcasts on Spotify at Nurses of TTSH.
And do give our channel a follow and click on the bell for notification every time we post a new video. And don't forget to give our video some love by clicking on the like button and dropping us a comment.
If you want more updates or opportunities to contribute to our future episodes, follow us on Instagram and TikTok at Nurses of TTSH. And if you have any topic suggestions at all or anyone you would like us to feature, like, Becky, for example, shout out to brother Eric for asking around and getting Becky on the podcast. So if you would like to be part of our team, please just hit us up and drop us a DM.
And we'll catch you in the next roll call. Have a great shift, everybody. Bye-bye.